ever wondered why your lungs can move thousands of times every single day without rubbing against the chest wall and getting damaged? Think about it. You breathe around 20,000 times every day. If there was no protective mechanism, every breath would create friction and every breath would be the painful. So what prevents it? The answer is the pleura. Imagine you buy a brand new smartphone, it becomes the inside cover and the phone is protected. Yet it can still move slightly inside the cover. Our lungs have also similar protective covering, and that covering is called the pleura. Definition is the pleura is the serous membrane and covering the lungs. Many students simply memorize the serous membrane. But why does the actually mean? Serous membrane is a thin smooth membrane lined by the mesothelium made by the flattened epithelial cells. Why flattened? Because flattened cells make the surface extremely smooth, and the smooth surface means the less friction. That's exactly what lungs need because they are constantly expanding and shrinking. So remember, pleura isn't just a covering, it's the friction reducing covering. Now here's something students often forget, that we don't have one pleural sac. We actually have the two pleural sacs, and one surrounds the right lung and one surrounds the left lung, and both lie on either side of the mediastinum. Here is the mediastinum in one lung, here is one lung, and here is covering pleura. Here's the reason that imagine one lung get punctured. If the both lungs shared one common cavity, air would spread both the sides and both lungs would collapse. That would be life-threatening because of the pleural sacs are separate. Damage to the one side usually doesn't directly collapse to the opposite lung. This is the brilliant anatomical design. Now it comes to the concept students find confusing. Each pleural sac is invaginated by the lungs from the medial side. Let's simplify it. Imagine pushing your fist into the balloon. Does your fist enter the inside the balloon? No. Instead, the balloon folds around your fist. Exactly the same thing happens here. The lung pushes into the pleural sac and pleural folds around it. This single idea explains why pleura has two layers. Since the pleural sac folds around the lung, one layer remains attached to the chest wall and one layer is attached to the lung. Therefore, every pleural sac has two layers. Outer layer is parietal pleura, and think of it as a wallpaper lining inside the thoracic cavity. And inner layer, visceral pleura, also called as the pulmonary pleura. Here's important question is that if there are two pleural layers, what lies between them? There are very thin potential space called the pleural cavity. Potential space, normally it is almost closed. It contains only very small amount of lubricating serous fluid. Why? So both layers slide smoothly during breathing, and think of two glass plates with the drop of water between them. They slide smoothly but stay together. Many students think visceral and parietal pleura are completely separate. They are not. Around the hilum of the lungs, they are continuous with each other. And remember this sentence exactly, both layers are continuous around the hilum. And very common viva question. Here's the development that embryology becomes easy if you understand the one rule. The embryo has the two important mesodermal layers. One is close to body wall and one is close to developing organs. The layer near to the organs is called as the splanchno-pleuric mesoderm, and it forms the visceral pleura. The layer near to the body wall is somatopleuric mesoderm. It forms the parietal pleura. Here is the memoretic splanchno, stomach or organs for visceral, and somato for the body, that's the make parietal. Let's compare conceptually instead of memorizing this table. Visceral is visceral by the splanchno-pleuric mesoderm and parietal by the somatopleuric mesoderm. Visceral pleura directly covers the lung surface and even enters the fissures. Parietal pleura lines the thoracic wall, diaphragm and mediastinum. Simple rule: organ, visceral, wall, parietal. Here's, don't memorize now. Nerve supply, we will understand the complete supply in the next parts. Now see the sensitivity. Here's the important concept. Visceral pleura is insensitive to pain. Parietal pleura is sensitive to pain. Then why does pleurisy cause severe pain? We will answer that in the clinical anatomy. Blood vessels are visceral bronchial vessels, and for parietal intercostal lymph nodes. Intercostal and pericardiophenic vessels are there in lymph node, intercostal lymph nodes, and for visceral tracheobronchial lymph nodes are there. This is the diagram for the pleuras. See, this is the covering. They are continuous at the hilum of the lung, and these are the parietal, and pink color is visceral. Let's see about the next part. Now we have seen the two layers and their development, where it's located. Let's start with the easier one, the visceral pleura. The visceral pleura is also called as pulmonary pleura, and it is in inner layer. It covers the entire surface of the lung, not only the outer surface. It covers the fissures between the lobes. And why does it enter the fissures? Because the fissures separate different lobes of the lung, and the pleura didn't enter them. Those surfaces would remain exposed and create friction during breathing, so the visceral pleura wraps around every visible surface of the lung. Here's the exception, that it does not cover the hilum of the lung and attachment of pulmonary ligament. Next we will see about the parietal pleura. It is the outer layer. Instead of covering the lung, it lies the inside of the thoracic cavity. And one interesting point mentioned in your notes, that it is thicker than visceral pleura. Now here's the important idea. As a thoracic cavity has the different walls, the parietal pleura lining those walls also receives the different names. Instead of memorizing 4 names, just imagine walking inside the thoracic cavity. Wherever the pleura goes, its name changes. 4 parts are there: costal pleura, diaphragmatic pleura, mediastinal pleura, and cervical pleura. Here's the memory trick: CMDC. We will see in detail the costal pleura. It lines the inner surface of the thoracic wall, and that means it covers the ribs, costal cartilage, intercostal spaces. And whenever you hear costal, immediately think about the ribs. Is it tightly attached to ribs? No, it is loosely attached because breathing requires movement and tightly fixed membrane would tear. Then we will see about the costal pleura is connected to the thoracic wall by the loose connective tissue called as endothoracic fascia. Here is the endothoracic fascia. Now more towards the center of the thorax, this central compartment is called as the mediastinum, and the pleura covering this region is called as mediastinal pleura. Simple. Here is the cervical pleura. This is one of the most clinically important part. Do the lung remain completely inside the thoracic cavity? Surprisingly, no. Apex of each lung projects slightly in the root of the neck, and naturally the pleura covering the apex also extends into the neck. This extension is called as the cervical pleura, and extension is called as also known as cupula of the pleura. Next we will see the relationship. Here is one point, that why doesn't it bulge out? It is the excellent question, that because the strengthened thick facial layer called a suprapleural membrane is also called the substance fascia. It is the covering protective cap of the lungs. Relations of the cervical pleura: anteriorly subclavian artery and scalenus anterior muscle, posteriorly neck of the first rib, structures lying over it, and laterally scalenus medius and medially large vessels of neck. Why cervical pleura clinically important? Because stab injuries or penetrating wounds above the clavicle can accidentally puncture it. This may produce pneumothorax, which will be learned in the clinical anatomy. Fourth one is the diaphragmatic pleura. It is the pleura covering the upper surface of the diaphragm, called the diaphragmatic pleura. It covers the base of the lung, and medially it becomes continuous with mediastinal pleura, and laterally it becomes continuous with the costal pleura. Again, don't memorize. Imagine a single bedsheet lining inside the thoracic cavity, and name changes depending on which wall is touching. Next part we will see the pulmonary ligament. This is the diagram. recesses we will discuss next. First we will see the pulmonary ligament. Imagine you are holding a curtain, and when you gather in the middle, fold hands downwards. Exactly the same thing happens here. Parietal pleura surrounds the root of the lung, and below the root, two layers become together and continue downward as a double layered fold. This fold is called as the pulmonary ligament. Your notes also mention that the fold contains the thin layer of loose areolar tissue and few lymphatic vessels. Instead of think logically, since this loose fold, it needs flexible tissue, not a dense tissue. That's why it contains the loose areolar tissue. Now comes to the real question, that why does ligament even exist? Nature never creates structures without the purpose, and the first significance that allow pulmonary veins to expand. During exercise, your heart pumps much more blood, and more blood returns from the lungs through the pulmonary veins. These veins need extra space to expand. The pulmonary ligaments provide the reserve space, and the second one is allowing lung movements. Every time we take a breath, and diaphragm moves downwards and diaphragm descends, lung root also moves slightly downward. Then there is one clinical point that mentions the functions of pulmonary ligament in just two ideas: expansion of pulmonary veins and allows the downward movement of lung root during the inspiration. Next we will see the pleural recesses. Now let's move on to another university favorite question. When you breathe in deeply, where does the lung expand? Does it already occupy the entire pleural cavity? No. Certain parts of the pleural cavity remains temporarily empty during the quiet breathing. These spaces are called as a pleural recesses. It is the potential spaces where the two parts of parietal pleura come close together, and they act as a reserve spaces for the lung expansion during deep inspiration. Think of them like empty parking spaces, and when the lung needs more room, it expands in these spaces. When the breathing becomes normal again, they appear empty once more. Don't say the lungs are absent from the recesses. During quiet respiration, lungs do not completely occupy these spaces. That wording scores better in the university exams. There are clinically important pleural recesses that are the Costomediastinal Recesses and Costodiaphragmatic Recess. Let's understand each. Costomediastinal Recess. Costo means ribs and mediastinal means the mediastinum. So recess lies between costal pleura and mediastinal pleura. It's very easy, and location it lies behind the sternum and near the costal cartilage in front of the mediastinum. Here's the diagram, shows the Costomediastinal syndrome. It's recess. It is the sternum, and here is the one empty space that's called as Costomediastinal surface recess. Next one we will see the important relation. This recess becomes especially noticeable near the cardiac notch of the left lung. Why? Because left lung has a cardiac notch, so this recess larger on the left side. This is commonly asked as a viva question. During normal breathing, anterior border of the lung almost fills this recess, therefore obvious mainly near the cardiac notch. And students often get confused when think it's always large empty space. It's not. Next we will see about the Costodiaphragmatic Recess. Where does the lung expand during the deep inspiration? Into the Costodiaphragmatic Recess. The name again explains the costal pleura and diaphragmatic pleura. According to this, approximately 5 cm vertically and 8th and 10th ribs are along mid-axillary line. These measurements are frequently asked in practical examination. During deep inspiration, these lung descend and expand into this recess. During expiration, the lung move upward again and making recess apparent. So remember, recesses are most obvious during expiration because they become occupied during deep inspiration. Here we will see the next part, nerve supply of the pleura. Let's think about the parietal pleura. The body wall receives parietal pleura. The body wall receives the somatic nerves, and so naturally parietal pleura is supplied by somatic nerves. And which pleura is attached directly by the lung? Visceral pleura. So lung supplied by mainly autonomic nerves, and then The visceral pleura supplied by the autonomic nerves. See, no memorization, only logic is there. Parietal pleura, somatic nerves and pain sensitive, and visceral pleura is highly non-sensitive. But parietal pleura is pain sensitive to touch, pressure and temperature. Let's discuss by dividing it into parts. Costal pleura. The costal pleura lines the chest wall, and since chest wall supplied by the intercostal nerves, and the costal pleura supplied by the intercostal nerve, very logical. Peripheral part of the diaphragmatic pleura supplied by the intercostal nerves and phrenic nerves. Then we will see the next part, visceral pleura. Does the visceral pleura feel pain? No. This is one of the most important concepts, that the visceral pleura is insensitive to pain. Students often think every pleura is painful. That's incorrect. Only parietal pleura produces sharp and localized pain. And here the nerve supply is over. Let's see the blood supply of the pleura. Parietal pleura, since it lines the thoracic wall, its blood supply comes from arteries supplying the thoracic wall, that include intercostal arteries, internal thoracic artery, and veins, azygos vein and internal thoracic vein. And visceral pleura, that's one easy. It covers the lungs, so receives blood from bronchial arteries and bronchial veins. Simple rule: wall thoracic vessels and lung bronchial vessels. Lymphatic drainage. Don't memorize blindly. Think logically. The visceral pleura, the lung drains into this visceral pleura, lung drains into the lymph nodes around the bronchi. Therefore, there are bronchopulmonary nodes. And then parietal pleura, lymph goes to the lymph nodes of the thoracic wall. These include intercostal nerves, posterior mediastinal nodes and diaphragmatic nodes, and internal thoracic nodes. Let's discuss about the clinical anatomy. Here is the referred pain that comes most interesting concept, that supposed to be pleura becomes inflamed. Will pain always be felt exactly at the same site of inflammation? No, sometimes brain misprints the origin of pain, and this is called as the referred pain. We will see the clinical correlations here. Imagine a patient comes to the emergency department. He says, "Doctor, I suddenly developed a severe chest pain, and while playing cricket, now I am finding it difficult to breathe. And what caused it happen? Did the lung tear? Did the air enter the pleural cavity? Did fluid collect?" All these questions revolve around the one thing, that is the pleural cavity. Here is one clinical, that thoracocentesis, called as the pleural aspiration. Suppose excess fluid collects inside the pleural cavity. Can medicines remove it immediately? Sometimes no. Doctor may need to remove the fluid using needle. That procedure is called as thoracocentesis, pleural aspiration. Then next question for you, that why above the upper border? Because each intercostal space contains neuromuscular bundle running along the lower border of the rib above, and if you insert near the lower border of the rib, you may injure these structures. Therefore, veins, arteries and nerves. Therefore, always insert the needle just above the upper border of the lower rib. Then next, pleurisy. Some patients develop the sharp stabbing chest pain. Pain increases during deep inspiration and pain while coughing. Why does the pain is so severe? Because inflammation usually involves the parietal pleura, which is richly supplied by the somatic nerves, and every breath causes the inflamed pleural layers to rub against each other. That produces the severe pain. Now understand why nerve supply is so important. Pleural effusion. Sometimes fluid accumulates inside the pleural cavity and called as the pleural effusion. Fluid may be serous fluid, blood, pus, or anything chyle. As the amount of fluid increases, lung get compressed, and patient complains the breathlessness, reduced chest expansion, difficulty in breathing, and again anatomy explains the symptoms. Next, the pneumothorax. Here's the one question, that what happens when the air enters the pleural cavity? Normally, the pleural cavity maintains a negative pressure that keeps the lung expanded. Once air enters, the negative pressure is lost, and elastic lung recoils and collapses, and causes the chest injury, rupture of lung, and penetrating trauma. This is remember the cervical pleura, and a stab wound above the clavicle can produce the pneumothorax. That's why anatomy matters. Hemothorax is the next part, that is the presence of blood, and these common causes include the chest trauma, injury in intercostal vessels, and lung injuries. Hydropneumothorax. What if both air and fluid present together? That condition is hydropneumothorax. And in emphysema, the presence of pus is there. Patient usually have fever, chest pain, breathlessness, and signs of infection. Here's one we have seen referred pain before these clinical anatomies. We have seen the referred pain, costal pleura, and mediastinal pleura. Next, these are the diagrams you will see. This is the diagram for the nerve supply. Cervical and costal parts innervated by intercostal nerves, visceral by the autonomic nerves, and the mediastinal and central diaphragmatic parts are innervated by the phrenic nerves. And today you didn't just memorize the pleura, you understood it, why it exists, and how it works, and why it is clinically important. When you study anatomy conceptually, medicine becomes much easier, and because every clinical condition has anatomical explanation. Thank you for watching. I will see you in the next video. Thank you.